Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. We were just an hour ago in Ireland and Britain, and we are now back in North America as well as back in Europe. Today we have on our final day of the webinar series of the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit with Greece as our host, Dr. Ioannis, and Dr. Tulio from Mexico. Welcome, gentlemen.
Welcome.
Thank you.
So we have a very exciting presentation about demineralized autologous tooth grafts. And it happens that last night we crossed the 2 million mark of peers reached that could range from dentists, dental specialists, surgeons, medical doctors, hygienists, surgical assistants, and other peers that make the patient care possible. So thank you for all your contributions, including the two gentlemen that are here with us today, one of our regents. Dr. Ioannis has been thoroughly introduced in the past due to his participation and hosting and other activities in this webinar series. Thank you, Dr. Ioannis. And we have achieved the unachievable together in a peer-to-peer fashion. With that said, Dr. Ioannis, you have the floor.
Hello, everyone. It's great to have more than 2 million of peers watching and see this huge marathon webinar. So I'm really happy, and thank you, Kiana, for that. Today, we have Dr. Tulio Alzaga Vega. He's a very good friend. I know him since many years. I visit him in Mexico, in Tijuana, and I have a really great time with him and his wonderful family. And I hope to go back soon. And Dr. Alzaga he received his DDS degree from Valle, California. But his passion was also always, since he was a student, oral implantology. So he took also a master in oral implantology, and is also diplomate of the Mexican College of Implantology and Maxillofacial Surgery. He's also a member of the Mexican College of Implantology and former president of Implantology College in Oya in California. Is also president of the local not-profit organization Ontología Especializada Asociación Civil, where their mission is to treat people who otherwise they have not the chance to do so. Dr. Alzaga is also coordinator of the oral implantology in periodontic residence at the Center of Dental Specialty. Dr. Alzaga, floor is yours.
Thank you. Okay. Hello, everyone. First of all, I would like to thank Dr. Ioannis for actually being here with us, and also for nominating myself, and Dr. Shaw for allowing me to be part of this amazing group of clinicians and researchers around the world. So I'm very excited to be here and share my experience. Okay, today our topic is going to be the demineralized autologous tooth graft: when, why, and how. But we have to understand that the term is somehow confusing. There's types of tooth graft. You can have undemineralized tooth graft, you can have partial demineralized tooth graft, and you can have demineralized tooth graft. The one that we're going to be presenting here is partial demineralized tooth graft. Although we use the term demineralized, I'm assuming because we want to have something different from other products out there in the market. But yeah, don't get confused. Usually, if you demineralize completely the tooth, basically you're gonna have a membrane. So we're gonna go over that topic. But yeah, let's just make sure that what we're gonna show today is basically partial demineralized. Okay, I have to say that all the information that I'm gonna share here is basically my clinical and my recent research that we have done actually over the years. but I don't have any financial interest on this company. Okay, during this webinar, we're gonna talk about the scientific background. We're gonna go over some clinical cases. We're also gonna discuss about complications, because I mean, complications is part of what we do, and we have to learn from the complications and to be able to solve those complications. Then we're gonna go over the conclusions. And we have to start by thinking about biology. I mean, there's always the situation that if we want to have long-term results, obviously they will depend on moving the right pieces at the right time. That's why biological understanding of the dimensional changes that will occur after extraction will be important to establish the ideal treatment plan for our patients. And as we know, there are several factors that can increase those dimensional changes. One of those can be team phenotype, team biotype, as also multiple extractions or periodontal pathology. So we have to understand that once we have to extract the tooth, socket preservation is going to be an option, and there's a lot of evidence about this procedure. We can find research from animal studies, from cases where they use only bone graft, when they use bone graft and membranes, using different kind of membranes, different kind of bone graft. And over the past 10 years, there's another product coming to the market, and that's autogenous tooth graft. There have been a lot of publications, the mineralized, partial demineralized tooth graft. So we got our homework, and we did our own research. So in this research, we were trying to histologically evaluate new bone formation in extraction sockets over 19 patients, and we were up to 27 sites. Basically, the procedure was done with the membrane made concentrated growth factors, and the wound was closed without releasing incision. After 4 months, we get a on each site, and actually we see good results. So I'm going to show a little bit of this publication that we recently did, and this is going to be part of the presentation. So why we use tooth graft? So first of all, we have to understand that it has a similar chemical composition, but we have to also understand that the inorganic portion of the tooth has 4 different calcium phosphates that give them the osteoconductive property, and also 90% of the organic proportion, it's collagen 1. Collagen basically will give us that wettability capacity. So so many others, we have seen in so many others lectures where doctor said that you can use saline water, you can use whatever solution to irrigate, and it's easy to handle because that capability of the tooth graft. And also we have non-collagen proteins, like proteins that it will help during bonification. We have morphogenetics and also growth factors, so that will give the osteoinduction capability. That's the reason why we use tooth graft. So what we did in those cases basically was automatic extraction. After the extraction, we cleaned the socket. As we can see here in this image, after the extraction, we can see that there's no buccal bone. So basically, before the placing of the bone graft, we use CGF or PRF membranes, and then basically we try to suture without releasing the tissue, because if we do that, definitely we're gonna end up losing bone, and at the same time we're gonna have only mucosa around the top of the crest. So this is the procedure after 15 days, and as you can see, good healing, but also we can start seeing here a little bit of dimensional changes. And 4 months after augmentation, we go back and use a trephine to collect the biopsy, and then that biopsy was sent to the pathologist, and this is basically the results that we got. This is basically at 4 months. What we have here is basically we can see a vital bone. In some areas, we can see still some of the pieces of the tooth grafts surrounded by vital bone. This is at 40 magnifications. We can see at 100 magnifications, and you can see the dental tubule and the surrounding bone or particle of the graft. So this is, I think, beautiful. This is one of the reasons we use this protocol. And how about our 400 magnifications? We can see the interlock connection between the part of the tooth graft, and also we can see the osteocytes and the new bone formation that we have. So we have a mature laminar bone with vesicular osteocyte gaps. But how about on the Mason trichome? So we can differentiate the vital bone here. A lot of osteocytes, so that gives us an idea to have good vital bone. And as you see, many remnants of tooth graft. So that's something important, because I think what we conclude in this study is that 4 months is the idea to back and place the implants. We also did a couple of samples at 3 months, and we decided that at that point in time, there's still a lot of cellular activity. We also did a couple of cases just to compare socket preservation with particulate bone and also with tooth graft block type. And basically, we understand that the ideal procedure is going to be socket preservation with particulate bone. I think tooth block is going to be helpful for other type of procedure, but it is more successful and more predictable to do it with particulate bone. But how about on the electron microscope? So what we can see here is that this is the undemineralized tooth graft. So we can see basically that Rebel's block dentinal tubules with mineralized tissue. Also, we can see here part of the collagen. So that's important. That's the reason why you can use undemineralized or partial demineralized. Again, the only thing is that we have to learn how to use it and when to use it. So we have goals here. So the only things is learn the protocols and then learn how it's gonna be the best scenario for us. We also did the same study at 30 minutes, and look at the difference here. Note that the sufficient exposure of the collagen fibers basically exposing the dentinal tubules, and as we know, when we expose the part of the minerals, we're gonna expose also the diverse growth factors on the periodontal tubule. So this is what we want to have. So the difference with undemineralized and partially mineralized is that this is gonna release the growth factor, so it will give you the osteoinductant activity that we want, and we're gonna have faster healing. So that's very important on patients that have some kind of compromised health, or in some bone deficiency that we want to have vital bone. We don't just want to have a material that will stay maintain space. And obviously that will be the case on undemineralized tooth graft, but it will take more time to resolve. It will take more time to the body. Also, we did this comparison. So what you can see here on the upper left, there's with no treatment, and you can see the dentinal tubule are completely blocked. At 30 minutes, I think this is the procedure that we're doing right now. 30 minutes, we give us enough collagen exposure. 60 minutes, it will depend. Again, depend on what you're doing. If you're using just the root portion, my suggestion is to demineralize. And here we're talking the block type. The particular bone, it takes less time, and it's a different procedure. So when we're doing a block type, I think 30 minutes, if we use only the root portion. If we're using the crown, this is important, 6 minutes, because it's makes sense that the crown obviously has enamel. Enamel has more minerals, so we need a little more time to basically remove those minerals. And I think that 90 minutes, it's a lot. I won't do that anymore. At the beginning, I was doing it because that was the suggestion from the company. Actually, if you demineralize for 90 minutes or even more, you're gonna demineralize 90% of the minerals. So I think basically you end up with the membrane, and that's not what we want. So I think that what we learned from this study is that 30 minutes, 6 minutes, it will depend on the portion of the tooth that you are using. But how about the bone quality of that that bone graft? And also we did a couple of cases where we use the mineralized and undemineralized tooth graft. What we can see here, first of all, is that the quality of the mineralized tooth graft or partial demineralized tooth graft is around D2 and D1. That's the ideal quality. Usually when we use mineralized, what we have is obviously a dense bone. Usually it's around D1, and it isn't bad. The only thing that we have to do is sometimes we have to give more time in order to go back and then place the implant. But definitely what we learn from this is that if we use mineralized tooth graft, definitely it's gonna be less dimensional changes. And I think that's a key to our knowledge, because later on during different kind of procedures, I think again today mostly I'm gonna show partial demineralized, but I think I have done cases with mineralized tooth graft. In some cases where I have enough vital bone around the implant, and I just want to have a contour graft, and I think that's gonna be the ideal material. And also we did a small sample of dimensional changes. So what we see here, basically the examples from left to right. So we can see that those three sockets are compromised. Those three sockets has infection. So basically, sometimes it will have more dimensional changes. And when we have a intact socket that you have completely all the walls, I think the results are going to be different. So what we can see, and I mean, this is not any scientific information. It's just I just superimposed the before and after, and obviously is not completely accurate, but it gives us an idea that when we have a compromised socket, then we're going to have a little bit more remodeling, but within what the literature says us. And when we don't have any when we don't have any compromise on the socket, I mean, there's barely no dimensional changes. So that's very important. So learn is that socket preservation minimizes but not prevent bone loss. So continue with the cases. That's what we did. Basically, 4 months after undimensional healing, we open a full thickness flap. We place our implants. What we can see here after placing the implants, we use this basically tool that it's called ProKit, that it's a replica from the abutment, so it can give us the ideal position of the implants, and we can also select the abutments the day of the surgery. So once we are clear with the position of the implants, we did a contour grafting, because remember, socket preservation minimize but do not prevent dimensional changes. And also, if we're open a flap again, we are compromising the blood supply to that area, so we are going to have more dimensional changes. So my suggestion is that although you do a socket preservation, then you have to do a contour grafting in order to compensate those dimensional changes after the implant placement. Then we did the poncho technique, basically using CEF membranes on top of the healing abutment, and we closed the wound without trying to get basically primary closure, without too much or too many tensions. We know that in that area the tissue will grow, and that's going to be the healing. So that's the healing of about 15 days after the implant placement, and that's the healing about 4 months. So we can see now that the initial dimensional changes that we have after the socket preservation, now it's compensated. And nowadays things are changing. We're using a small diameter implants to give enough space for the soft tissue, and then we can start working on the immersive profile. If we give enough soft tissue, then we're going to have enough blood supply, and basically we're going to be more predictable on the protocols that we're doing. Okay, but how we do this protocol? And again, as we know, there are two type of a tooth graft. Basically, you can do it particulated and you can do it block type. The block type will have different ulcers also. So we're gonna go over the particulated bone. First of all, after the atraumatic extraction, you have to remove all the soft tissue, all the foreign particles, and clean the tooth. Usually, what we're doing it's after extraction. We use a hand piece, or you can use a blade if you want. Completely remove all those foreign particles, then put it on the alcohol. The alcohol will actually dry faster, and so you can start crushing the tooth. You're gonna repeat this process for about 5-7 times until you get the size of the particle that you want. That size it's around 0.8 to 1 millimeter, or 250 to 100 microns. So that's also very important, because what we learned from the study is that if you use undemineralized tooth graft and you use the portion of the crown, bigger particles of the enamel will not be resolved. So the osteoclast activity is not going to be the same. So you're going to basically encapsulate that bone, and you're not going to have new bone formation in that area. So that's critical to know. Then the process is basically simple. We're going to use a couple of chemicals to demineralize, sterilize, and then balance the pH on those chemicals. So what we're doing right now, although we can see here that it says 20 minutes, on the particle side we're using only 15 minutes. 15 minutes. The 15 minutes right now it's equals like about 50% of the. And how a tube block? Tube block, like I said, it's a different particle, because tube block you can have different options. You can use it as a tooth ring, you can use it as a laminate, or you can crush and have a bit bigger particles after the mineralization. For some cases, like sinuously. However, the process has changed. At the beginning, what we were doing, it's we basically cleaned the tooth the same way we did it with the particulated bone, and we go ahead and try to demineralize and sterilize the tooth. And actually, that's not very clever, because as we can see here at the beginning, we're kind of excited to see that look all the minerals that we remove, and we have a very spongy material. But I mean, nowadays we understand that this is basically a membrane. We basically remove all the minerals. So this is not what we like to have. So now what we're doing is, after the extraction, we clean the tooth. After cleaning the tooth, basically we're gonna use a disc of a diamond disc, and then we're gonna trim and create the shape we want. And this is something that I will suggest. Most of the clinicians using this system, they just cut the tooth and leave a flat surface. As you can see here, I'm creating a concave surface. Obviously, this is gonna be used as the laminate, basically to do something similar as the Corey technique. But by creating this concave space, you're gonna allow some particulate bone to be placed in that area. Remember, this lamina of tooth graft, it will create like cortical bone, but you still need underneath that cancellous bone that is gonna be basically surrounding the implant. So my suggestion is to once you trim and create the ideal shape, try to remove a little bit of the structure of the tooth and create this concave space in order to allow some particulate bone to be placed in that area. Okay, so that's one of my uses. So when we're gonna use it, and basically the answer is very simple. We can use it from simple socket preservation, as we see in some of the examples that I give you, but we can also do it in any alveolar ridge reconstruction, and also on sinuously. But the thing is that how are we gonna do it? Can we resolve all the cases the same way? The answer is gonna be probably not. So what we have to do is we have to understand the patient's needs, and then basically we have to think what's gonna be the best possible solution for this patient. And basically, my approach on this type of cases is that it's very simple. In cases like this, I think that we need to have a vertical reconstruction. I think we're gonna go stage by stage. We're gonna do a stage approach. That means that we're gonna do the grafting procedure. We're gonna wait, and then we're gonna expose the implant. That's how we're gonna do it on the vertical defect. Horizontal, however, it's a different situation. So we have different 4 different examples here of horizontal deficiency. So horizontal, it's you can approach this type of particles different ways. If you need to have, or if you have bone and soft tissue deficiency, and plus, like in this example, we have a prosthetic compromised space, I think we're gonna go with the stage approach. So that means that we're gonna graft, and then we're gonna place the implants. However, the other 2 options where we can have the ideal implant position, we have at least 2 millimeters of keratinized tissue. Uh, um, we have enough bone to basically anchor the implant and graft around those implants. I think we're gonna graft, and not only gonna graft, we're gonna try to do immediate loading, because we're gonna try to basically do more with less. What I mean is try to reduce the treatment time for our patients. So this is what we're gonna try to explain during this webinar. Basically, nowadays we're working on a different protocol, and we're still using block type in the cases that I explained, where we have to do a stage procedure, and most of the time we're using articulate type cases that we want to approach immediate loading and try to reduce the treatment plan for our patients. So nowadays I'm working on this protocol. I think this is a protocol that it is not new. Basically, it's I'm not discovering anything. What I'm doing here is just collecting the information that we got from the literature, and then just trying to create a simplified protocol. So what I'm doing, it's what I call it's a simplified contract tension grafting technique. But the difference here is that, again, what I'm trying to achieve is place the implant, have a good primary stability, graft on basically on layers. The first layer is gonna be demineralized or partially demineralized, as we already explained. Then we're gonna have a second layer of xenograft, and then different layers of CEF. As we know from different studies from Professor Song, is that there's no need for a membrane. You can use CEF membrane, and that will give you good healing without the need of a collagen membrane. And the difference is that here in this image, we just do a stage procedure, but usually in our clinic, we try to do it medial loading with the protocol 1 abutment 1 time. So I will try to share some of my cases. And again, the rationale behind this is simple. It's again, I'm just following the some of the articles that are out there right right now, and basically I'm doing something similar. In both of those articles, they use autologous tooth. They collect the autologous bone. Sorry, they collect from the surrounding area, and they use that autologous bone as a filler. Then they xenograft, and they use different kind of membranes. Actually, a couple of membranes on the protocol from Dr. Boozer. So again, this is something similar, but with different materials, but the rationale is basically the same. And then I'm gonna go over the cases, because definitely we don't have time to extend our lecture. So first of all, every time we start a case, we need to have good communication between the patient, the lab, and the clinicians, and all the team that is going to be involved, because there will be some teams that it will be with the surgeon and the prosthodontist. In my case, I do from start to finish, but definitely communication it's part of the success. So what we're doing here is that, first of all, we have to clinical examine the patient. Then after the clinical examination, we take impressions. We create a WhatsApp. We duplicate that WhatsApp, and we create this surgical stent, and we call that multifunctional guide, because that multifunctional guide, it will be a radiographic stent, also is going to be a surgical stent, and then at the end of the surgery, it will allow us to pick up the implant position with the ideal occlusion of the patient. So I think this is a very clever option to work. And again, what we see here is that we have a lot of bone deficiency. Every time we have a horizontal deficiency, it's more likely that when we start drilling, we're gonna create a dehiscence or a fenestration. So we already understand that situation. And what we're trying to do here is that before the process, we're gonna extract a couple of teeth. Basically, this is number basically 15 in the US and number 1. So we're gonna go ahead and extract those teeth to create the tooth graft that we need. So this is the multifunctional guide. So we played after the full thickness releasing full thickness incision and flap. We use the guide to give us the ideal position of the implants. Usually in all the procedures nowadays, we're working with osteodensification because we want to improve the bone to implant contact, and we want to avoid removing the bone in cases where we don't have too much bone. So again, we're not afraid of this situation. We know that we're gonna have some fenestrations and some exposure of the threads of the implant. So we place 6 implants. The idea is to then, after the final resolution is gonna be with 3 different bridges for the patient. Once we have this situation, we're not completely comfortable with this implant because, as you can see, after placing the implant, we basically have not have good primary stability. So we decide to change that implant. Instead of putting 1 implant to have a bridge from lateral to lateral, we move it to the central area. So I mean, we didn't change too much because it will be the same thing. Now we're gonna have a bridge here with the cantilever on the lateral. We're gonna have bridge here on the cantilever here. So again, it's just trying to create or have a good primary stability to achieve immediate loading. So this is basically after implant placement. We, as we already said, we use in this case multi-unit abutments, or what the company called these abutments is neodymium implants, so they call mini pillars. You can see 2 different type of one. This is a 0 degrees angulation, and this has a 17. So that's the reason why you can see 2 holes here. One hole is to basically adjust the abutment and into the implant, and the other one is gonna be for the restoration. So this is the multifunctional guide. What we want to do here is basically we want to pick up the implant position and start working on the restoration. So once before we do that, we start our grafting procedure. And again, the first layer is gonna be tooth graft, as we can see here. Basically, you have to extend completely around all the areas of the implants. The second layer is going to be xenograft. The xenograft basically is going to just the tooth graft. And again, the first layer of tooth graft is because we know that it has some osteoinductive capacity, and it will give us the more osteogenic properties that we know. The xenograft is just basically to protect. And on top of that, we're going to use different layers of CEF. And this is very important because most of the question that always the doctor asks is how many layers of CEF? And I will say that as many as you can. What I do is I create kind of like a net of CEF membrane, some horizontal, some vertical. So we have to make sure that we completely all the bone. If we leave some spaces like that, the epithelium will migrate faster, and then we're not going to have good healing. So I think that it is important to cover completely all the areas of the bone, and then you're going to have good results. So after doing that, this is the resolution after 4 months. And as you can see, obviously, there's a good quality of the soft tissue and obviously the good volume that we have. So what we end up doing, we have three different bridges. One in the anterior, 4-unit bridge, 1 4-unit bridge here, and 1 3-unit bridge. So I think the patient was very happy because actually at the beginning, some other doctors offer basically a type 5 restoration. That it means it's gonna be like an over danger. So once we do a good diagnosis on this patient, we understand that we can do probably a fixed prosthesis number 1 or number 2, because this is a little longer crown, probably around 11 12 millimeters. But I think it's a lot easier to maintain that the type 3 prosthesis, like the hybrid one. Oh, different cases that we have. Another example. And as you can see here, this is not the way the patient presented to our clinic. Actually, before this picture, I apologize because I didn't find it, but the patient comes with the broken bridge, and what we did is basically we'll build up those canines. We created wax up, we duplicate that wax up, and we have a provisional, and that's going to be a key, because every time we are listening to a lecture or the webinar, most of the time the doctors say, okay, we have to place the implant on the 3-dimensional position. But so many times we have that, but in so many times we see that that's not the way they are approaching their cases. So the only way that we can approach that is by using a surgical stent. You can do it guided, or you can do it freehand. So it will depend on your skills and your capability, but definitely you need to have some kind of stent in order to guide you, to allow you to place the implant on the proper position. So here again, we did we'll take this flap and we create a replica of the provisionals to basically allow us the ideal implant placement. As we know, some of the most difficult situation is always the apical coronal position. Many times we have seen implants that barely at bone level, sometimes even supracrestal, because some doctors are afraid to place the implant deep. And as we know, it will depend on the connection. But as you can see here from this image, the ideal apical coronal position basically is going to be, in this case, around 2 or 3 millimeters below the bone. So what we have here is, once we have our replica of the provisionals, this is the gingival margin of the restoration. From here to here, we need to have at least 4 millimeters. So that's the reason why we use this protocol. And since we already have the provisional, we just basically pick up the abutments, and while suturing, some of our assistants is just using flowable composite to basically create the ideal emergence profile, and the patient will have the provisional. So before the grafting technique, it's always important to do a periosteal releasing incision. At least in cases like this, you have to be able to rotate the flap at least 3 to 5 millimeters over the palatal side, because you need to create the ideal space for the bone. So the same protocol, the first layer is going to be tooth graft. The second layer is going to be xenograft, and then different layers. As you can see here, you cannot see any particles of bone. Different layers or different numbers of layers of CEF, and basically we just close the wound and allow the patient to heal. And this is the results after 4 months. And as you can see, good quality of keratinized tissue, good volume, and we were able to manage the emergence profile. Although we have 2 implants that are together here, I think the results were very, very exciting. So what I would do now is I'm gonna go because of time. I'm gonna show the way that we work on a daily basis, because basically, yes, we are focusing on tooth graft, but I think tooth graft is not only what we need. We need to establish a good diagnosis, and then we have to execute. So how are we gonna start that? Well, first of all, again, like I said, we have to do our clinical evaluation of the patients. Then we have to gather all the information that we can. Part of that information is photography. It's try to implement all the good quality of pictures that can give us some information from the patient. So this is the clinical situation of the patient. This is a young lady that lost her teeth when she was younger. So what we did in this case, that's that we were planning to place 2 implants on both centrals. So the idea was to create the protocol. So we start by taking out the wisdom teeth. Usually, in these cases, when we can, most of the time we doing it on the same. This was the few local patients that we have. We were able to do it like about 3 or 4 weeks before the implant placement. So once we do that, we store the graft, and then we start working on the planning. In this case, we did a guided case. And remember, when you do a guided case, you can have 3 different options. You can do it fully guided, you can do semi-guided, or you can do just intermediate drill. To be honest, that's the way I'm doing it, because if you do fully guided, in cases where you have too little bone, you're gonna end up losing that bone. So what I want to have in this case is just the ideal initial drilling. After that, I'm gonna remove the guide, and I'm gonna use osteoinsification to enhance the basically the bone around the implant, and then we're gonna graft. As we can see here, we notice that in some areas, if we use the regular drilling, or even by using sometimes osteoinsification, we're gonna have some kind of fenestration. So what I'm trying to do is just push the bone and try to create a better environment for that implant. So after basically designing the guide, what we did, we have a in-house 3D printer. So this is the way that we do it. And again, there are many different sleeves over there in the market. This is one of the ones that I like, because it allows you to have a lateral access, and also you have good irrigation. So irrigation is one of the critical situations every time you're doing guided surgery. So this is the one that we use. And again, we go to our patient, and again, we start here by creating, like Dr. King says, is basically we're getting a trick under the head, because again, if we already deliver some kind of papilla by creating a flipper from the patient and pushing the soft tissue, we want to maintain that. So what we did here is basically like a paracrestal incision. We did a full thickness flap, but we leave this portion of the papilla basically attached to the palatal side, so we can ensure that we're gonna have enough blood supply. And then we're gonna use PSO surgery to clean and prepare the recipient side. Once we do that, again, like I said, basically initial drilling with the guide, then we remove the guide and we use osteoinsification. This is a protocol that I love, because in all the cases, we can improve the implant stability. We can improve the bone to implant contact. I think nowadays it's a procedure that it's have been done. Basically, every doctor is doing this protocol. So after the drilling sequence, we place a 3.3 by 14 implant. Basically, the length of the implant, it's what gives us the ideal ability. Nowadays, we're working with the small diameter implant because we want to have less titanium and more bone. And again, every implant that I use in my office, one of what the clear or the way that I evaluate how to use the implant is that the conical connection has to be stable. The connection of the implant has to be conical, and that's the more stable connection that we have. So after implant placement, we use biological modifiers. Already other speakers talk about this topic, so I'm not gonna take too much time on this. But basically, we take different colors of bile. Usually, again, depending on the protocol, what I'm doing is that once I open the flap and I see how big of the defect I have, I will determine how many vials I will need. At the beginning, we were doing it without thinking. We were just, before we go and do the anesthesia of the patient, we draw the blood, and sometimes we got not enough volume of membranes that we need. So nowadays, what I'm doing is I open the flap, I understand the dimensions of the defect that I have, and then at that point in time, I will decide how many vials that I need. Once you centrifuge, you're gonna have two different situations. This is the liquid, the autologous glue that is gonna be mixed, in this case with the tooth graft and the seal graft, and you have the membranes. This is the CEF membrane that we're gonna use. Basically, this is one of the alternatives that will give us improved particulate handling of the graft. it's gonna be a lot easy to manage the tooth graft. It will give us graft containment. We will decrease the graft micro movement. It is a fiber network for cell migration, improve angiogenesis, and also improve soft tissue healing. This is a protocol that by my dear friends. I have the privilege to know them for a few years now, and I can say now that I'm part of the Sticky family. So this is what we got. And this is a picture that I like because now I have like about 4 years using this protocol. And I said earlier, in this case, we did the extractions and then we stored the graft. At the beginning, I didn't know what we were doing. Actually, we just read information, doing some cases, but I was not completely aware of the situation. And you can see here, this color looks weird, right? What happened is that every time you store a graft, then you have to use a buffer solution because this is when you store the graft, you use a sterile solution that it's also an acid. So if you remove that, you're gonna have this type of situation. That's the reason why we have this color. And I was trying to get information and go to and do some research, and basically what I got is that they told me, you know what, there's no problem. The only thing is that the problem that the patient can have a little more pain because you're putting basically acid on the mouth. So this is how I learned from my mistakes. But hopefully, and actually, the results was amazing, and I didn't have any complications. But this is something from what I learned at the beginning. So the first layer of tooth graft, second layers of xenograft, and then different layers of CF membranes. And usually in cases like this, we create two types of provisionals. The first one, it's basically completely concave. We don't want to push the bone. We don't want to push the soft tissue because at this point in time, we can have recession. So that's the reason why we create two types of provisionals. Once the soft tissue heal, we're gonna evaluate, and we have the different articles that can give us an idea. This is an article that I think he can give you those type of options. When the implant is a slight level, you have to have a concave immersion profile. If the implant is center, you have to have a slight concave. If the implant is palatal, you have to have convex. But at the beginning, when everything is healing, we always want to have concave resolution. That's what we have. And this is basically another one that it's basically very important in our practice because the way we manage the critical and subcritical contour, it's very important. So again, this is got to be the second provisional. And in order to create the illusion of having a papilla here, this is what we do. In between the implant and the tooth, we have a concave subcritical contour. But in between the implants, remember that the distance from the bone to the point of contact in between implants is around 3.5 millimeters. So what we're gonna do in order to basically create that illusion of having a papilla here is we're gonna create a convex portion of the interproximal space in between the implants. So we're gonna push the tissue and we're gonna create the space that we want. So this is the emergence profile that we have, and as we know, long-term aesthetic success require sorry about that. Require bone to support the healthy keratinized tissue and dictate the tissue profile, which will follow the underlying contour bone. So that's critical to manage this situation. Once we have this, it's basically we just have to send this information to the lab and start working on that. So what we did is basically a custom impression in order to basically duplicate that emergence profile, send it to the lab. In this case, we're gonna do a CAD/CAM restoration, but we did a small cutback in order to give the ideal translucency of the restoration and give a little more aesthetics. This is the day of the insertion of on the final restoration, and look at the difference 4 years after that. So we can see now the integration of the soft tissue. Actually, we can see some inflammation on the rear and the adjacent teeth, but again, the area around the implant looks really, really nice. The quality of the tissue is really nice, and actually, you can see the integration of the tissue. This is a close-up picture where you can see the soft tissue. You can see basically the texture of the tooth. That will be very, very important, most in younger patients. So I think the results were very, very encouraging. And this is a small sample of some of the cases that I have, and I wanted to share with you because I think this is important. Every time we're doing a bone graft, most of the time, what we get, it's a mass of graft that it will be completely white. But again, we cannot say that's going to be by bone. So what we're trying to accomplish with this protocol is that, as you can see in the examples here, you have cancellous bone cover, but by dense bone here, by cortical bone. So that's what nature needs. As you can see in the areas of the lingual side, this is cortical, this is cancellous. So we need to have that same thing on implants. And as you can see in all the examples, it's the same thing. We have a cortical bone, it's created with the xenograft, and we have cancellous bone that's basically surrounding the implant. So again, this is a small sample. I have a lot of more cases, but again, because of time, it's difficult to show. But how about complications? Because again, complications are an important part of what we do. And there's only a couple of systematic reviews on this topic. Actually, although this article is not too friendly for those who use tooth graft, but I think it is important. We have to mention. First of all, it's difficult to say that every product, every protocol is gonna be the same, because you have different advantages. Again, as we said at the beginning, we can use mineralized and we can use partial demineralized. The partial demineralized can be demineralized on different ways. You can use chloric acid, you can do EDTA, lactic acid, or other acid. So the results will be different. So we have to establish a protocol in order to have good results. So that's why whatever protocol you're using, you have to follow that protocol and basically understand what possible complications that you have. So I'm going to show my complications. So this is at the earliest stages of my use of tooth graft. This is what I was doing. Again, what I explained at the beginning is that we process the tooth without creating the ideal shape, and these particles basically were then exposed, because as we know that we cannot leave a sharp edge of the graft, because definitely it will create some adhesions on the soft tissue. So this is some of the complications that I have. So what I'm doing right now, again, it's basically create the ideal shape by trimming the tooth graft. And this is another histology that I want to share with you, because in one of the cases that you see, we collect the bone, and this is what we have. Look, this is bacteria. This is the portion of the tooth that it's exposed, that is contaminated with bacteria. But down here, we still have the portion of the tooth that is not contaminated. So that's really good, because you cannot say the same thing with autograft. Once the graft is exposed, everything is gonna be missed. So I think this is a encouraging information, because I think now we understand that if we remove that portion, we're gonna be able to continue to trim it without any problems. And there's a couple of research about that. Also, the high variability and resorption time. Again, at the beginning, I was showing that we were doing about 90 minutes or even more. And again, what we can see here is basically we have collagen. This is not what we want. Again, they will depend on the protocol that we're doing. Now we are using a different protocol. So this is a summarize of what we're doing. We trim the tooth at the shape that we want. Then we will demineralize about 30 minutes, 60 minutes, depending on the portion that we're using. If it is only the root portion, I think it will be 30 minutes. If it is the crown portion, you will have to do 60 minutes. Then we have to fixate that block. And in some of the cases at the beginning, I was just putting in position and covering with sticky bone. Now we can see the results. This is basically at 6 months. And look at the quality of the integration here. I think in order to avoid this type of complication, what we're doing right now is pre-shaping the graft. We create microperforations in order to allow the rapid vascularization. We demineralize for 30 minutes or 60 minutes, depending on the portion of the tooth that we're doing. And again, stage approach. We graft every time we use block type. We have to do a stretch approach in order to cover completely and allow the healing. And basically, this is the results. As you can see, this is the beginning after the implant placement. This is obviously after exposing the implant. So again, I have to say that knowledge is power, but the power to give you the ideal treatment for our patient. So with this, my conclusions are that autologous tooth graft is considered a novel graft for risk preservation and augmentation. However, it's not a magic one. So you need to have a protocol. And my protocol is to use a three-dimensional image in order to create the ideal three-dimensional position. I use piece of surgery to prepare the recipient side. Then I use osseodensification to have a ideal bone to implant contact, and then biological modifiers as CGF and sticky tooth. Well, with this, I would like to thank for allowing me to share my cases, allowing me to share what I'm doing, and I'm going to be here basically to try to answer some of the questions by the audience. I cannot hear you. Oh.
I said congratulations, was a very interesting, very nice lecture. I like to know why you said it's important to have the different layers. I mean, first the autologous bone, if after the xenograft and after the biological membrane. That's right. Why is it important to have more these layers?
Well, the thing is that one of the problems we have with tooth graft is volume. I mean, not always we're gonna have a tooth to use it as a bone graft. If in cases, again, because of time, I didn't show all the cases, but in cases that, let's say we're gonna do a full arch and we have to do extraction, I would not use any xenograft because I have a lot of bone, a lot of tooth. So what I do in those cases, I would use the root portion as a unit layer to have a good vital bone, and in the crown portion, again, you have a more dense material there, so to cover and protect the bone graft. Because again, what we're trying to have, it's that combination of cancellous and cortical bone. Every time we do a grafting procedure, again, we just have a mass of bone. We don't know exactly what it is, and most of the time we didn't even have bone. We have just something maintaining the space, and that's we because we don't think about biology. We have to think about that process. But again, in case where I don't have enough volume, that's the way I use it.
Very good. Another question is why you like to have this concave surface.
Again, if you're using the current technique, in this case with tooth graft, if you have a flat surface, basically you're not creating the ideal space for the bone. So sometimes you put just and some of the what I see from other colleagues doing the same procedure is that they just use that cortical portion of the tooth. And again, remember, we need to have cancellous and cortical portion. So if we have a concave space, we're gonna use some particle bones. That portion will be cancellous, and the block is gonna be basically cortical bone. So that's what nature is, and that's what we want.
And you prefer to use concentrated growth factors to create a sticky bone?
Yeah, usually every case I use it. I think that's part of the success, because again, like I said, improve the healing and the handling of the bone graft. And I think definitely it is a protocol that we always do.
Last question is, how much percent we need to have a demineralization of the autologous tooth?
Yeah, what I'm doing right now, it's about 50%. No more than that, because again, if we understand that the dentin is the one that has more similarity to the bone, and it's around 70, 75. Again, it's something around that. If we remove just 50%, we still have some minerals that will be important to have to maintain this. So that's the reason why we partially demineralize, because by doing that, we're gonna expose the growth factor in the BMPs, but at the same time, we're gonna have a material that will maintain the space. So we have everything together: inductivity and conductivity.
So, thank you very much, and I hope to come back to your very nice dental center with all the innovative equipment inside. Thank you very much.
Whenever you want, you're always gonna be welcome.